What's up, Ninja Nerds? In this video today, we're going to be talking about gastrointestinal perforation. This is a part of our clinical medicine section. If you guys like this video, it helps you, it makes sense, please support us. And one of the ways that you can do that is by hitting the like button, commenting down in the comment section, and also subscribing. I really urge you guys to really understand this topic. I think it really benefits you to follow along with some notes, follow along with some illustrations, and even test yourself to see if you really understand this topic. And the way that you can do that is by going in the description box below, click on the link that goes to our website, become a member. You'll have access to all of those things, and I think it will really, really help you. Please do that. And there's a lot of other cool things that we're offering there as well. Let's talk a little bit about gastrointestinal tract perforation. So there's two areas that I want to focus on. One is in the chest, and that's the esophagus, and one is in the abdomen and pelvic area, and that's going to be the bowel, so the small and large bowel in general. Whenever these organs perforate, we call it a perforated viscus, a hollow organ, it can cause a lot of potential complications, and these patients can go downhill pretty quickly if this occurs. I think it's important to understand the classic presentation, the pathophysiology, and the associated causes. So let's talk about that first. Well, when I do this, I want you guys to have just a basic anatomical understanding here. So I'm taking a cross section of the actual thorax, and what we're looking at here is the lungs in blue, and the pink here is what we refer to as the mediastinum, right? It's the mediastinum. And then inside of the mediastinum, you have your heart, which sits in a cavity called the pericardial cavity. You have the trachea, and then you have your esophagus. And patients who develop esophageal perforation, it's literally what it sounds like, the esophagus can perforate. So the intraesophageal contents can now be released into the mediastinum. And this could be bacteria, and this could cause a lot of potential problems. And it also could be air, which will represent them in this black color. And so you can end up with what's called a pneumomediastinum. And then bacteria can infect the mediastinum and cause mediastinitis and then potentially sepsis. So we'll talk a little bit about that in the complication section. But when the esophagus perforates, it causes a massive amount of pain, and it's usually located in the chest. And so I think the big thing to watch out for is a patient who comes in with intense chest pain. You really want to watch out for that. So when the esophagus perfs, it may cause an intense chest pain. All right. Now the question then arises, what's causing this intense chest pain? Well, it's the esophageal perforation. What's causing the esophageal perforation? Well, it comes down to three pathophysiological concepts. One is the easiest one. Is there some type of trauma to the esophagus? Oftentimes this is pretty easy in the sense that, in patients who have, let's say, upper GI bleeds, and they have to get scoped. So we send this little scope down, and sometimes, unfortunately, this scope can potentially hit the wall of the esophagus if we're doing an EGD. So we call this a EGD. It's a esophageal gastric duodenoscopy. And so sometimes what happens is if you kind of abut this wall and hit this wall, it may literally cause perforation. And so this is a really, really important one. Oftentimes this can happen just naturally, iatrogenically, as a part of the procedure. Another thing is even more simply than that, it could also just be any kind of traumatic injury. Like, if it's not an EGD, maybe it's a stab wound. So think about that as well. Not only is it going to be an EGD, but could this just be like a generalized stab wound, like you get hit in the chest with a tomahawk or something like that, right? So I think these are the big things to consider here as potential causes of a traumatic injury that will cause perforation of the esophagus and releasing of that intraluminal contents out into the mediastinum. Second one is the pressure is just too dang high. So when the pressure in the actual thorax is high, sometimes this can be transmitted to the esophagus. But you have to think about what's the reason why that esophageal pressure is so high. Oftentimes it's because a patient is trying to vomit. And so oftentimes with crazy excessive vomiting, sometimes after a patient goes on like an intense alcoholic bender, this vomiting really increases the pressure. inside of the esophagus because you're constantly trying to vomit and you're trying to create this pressure to suck the actual vomit out and then vomit it out, unfortunately. But the pressure is so dang high in the esophagus that whenever this gets exerted onto the wall of the esophagus, it may very well be enough to cause a perforation of the esophagus. And this type of perforation, which is actually secondary to vomiting due to an intense alcohol bender, is what we refer to as Boerhaave syndrome. And so I want you to think about that whenever you hear a patient, oh, do they have Boerhaave syndrome? It could be vomiting related. Increased vomiting increases intrathoracic pressure and causes perforation of the esophagus. Think about Boerhaave syndrome, okay? So if they come in, intense chest pain, did they just have any instrumentation like an EGD? Did they get stabbed? Pretty obvious. Or have they been vomiting profusely? That could suggest Boerhaave syndrome. The last one is, do they have any history of intense esophagitis? So sometimes if a patient has really, really bad esophagitis, in some degrees it could be GERD related, but oftentimes this esophagitis is so bad that it can really erode through the wall. All right, and when it erodes through the wall, it literally can completely erode through and cause perforation. Oftentimes this type of erosive lesions of the esophagus is not usually due to GERD. It's due to something like really, really caustic. And so sometimes we see this in what's called caustic esophagitis, where a patient tries to commit suicide and they just try to pound down a ton of bleach. And that causes nasty erosions of the esophagus, and oftentimes they'll present with like drooling and stridor and difficulty breathing, along with difficulty and pain with swallowing. Another one could be infectious esophagitis, but you're usually looking at this in a patient with underlying kind of an immunocompromised state. And so if I see a patient who has someone like HIV or AIDS, then I definitely would be considering, do they potentially have, CMV, HSV, something that's causing some type of erosive nature of the esophagus. So I want you to think about infectious lesions, and I want you to think about, again, potentially, could it be infectious or could it be caustic esophagitis that's inducing this process? So if a patient comes in, intense chest pain, you definitely want to rule out all the other causes of chest pain. We talked about this in the cardiology section. Think about the mnemonic PET-MAC. One of those is esophageal perforation. If it's an esophageal perf, think stabbing, recent instrumentation, excessive vomiting, Boerhaave, infectious caustic lesions. Do they try to kill themselves? Do they have any immunocompromised state? Now let's talk about bowel perforation. With bowel perforation, this one's really, really scary, okay? Oftentimes what happens with this one is, again, anterior, posterior portion. We're taking a cross section through the abdomen, pelvis area here. And what you're noticing is in that pink up there, that was mediastinum. The pink here is peritoneum, right? It's peritoneum. And so here's the bowel. And when the bowel perforates, it empties its contents, such as maybe fecal material, which is rich in bacteria, into the peritoneum, or it empties things like air, which is definitely a very common component, into the actual peritoneum. And so patients can develop pneumoperitoneum from the air, but they can also develop peritonitis, which can lead to terrible abdominal pain, and on top of that, septic features. When a patient does perforate their bowel, and this does perforate into the peritoneum, oftentimes it causes an intense abdominal pain. And so one of the things I definitely would be concerned about is if a patient comes in with like just really, really bad abdominal pain, I would really be concerned, especially if they have findings of like peritoneal findings, which we'll talk about next in the complication section. But if this abdominal pain is accompanied by rigidity, guarding, rebound tenderness, I would definitely be concerned about an abdominal perforation or a bowel perforation. The question that arises is what's causing the bowel to perforate, which is precipitating this intense abdominal pain and peritoneal findings? Well, one of the big things is it's a kind of straightforward traumatic injury. In this case, it's not necessarily an EGD. Oftentimes we can do this other test where you have a patient who has, you suspect some type of biliary disease. Maybe it's a gallstone, or you're trying to look through their biliary tree a little bit better. And you take this kind of scope and you're trying to run through the actual small bowel. And then what you do is you try to run this thing via the pancreatic duct and then up into the biliary tree. And usually you use it to kind of retrieve some type of stone, right? But sometimes what can happen, unfortunately, is that this can potentially hit or puncture the bowel inadvertently and can cause an iatrogenic injury. And so this is one to definitely think about. What is this here called when you're trying to go up through the biliary tree? This is called an ERCP. So have they just had a recent ERCP? That could definitely be a cause of a bowel perforation, especially like small bowel. And then again, could it also be like a stab wound of some sort? Did they just get stabbed or had a bullet wound to the chest, right? I'm sorry, to the abdomen. So these are definitely things to think about. Stabbed, recent surgical procedures like an ERCP. Another one is really, really common. I'd probably say out of all of the bowel perforations, this is probably up there as the most common cause of a patient developing a bowel perforation. That's usually due to an erosive lesion of the stomach. And this is a disease called peptic ulcer disease. So there's these nasty ulcers that really kind of traverse through the mucosa, submucosa, muscularis externa, serosa, and they completely eat through the actual stomach wall. And this will 100% most certainly, as this continues to erode and erode and erode, it will cause these patients to kind of bleed, but also cause them to perforate into the abdomen. So peptic ulcer disease is a really, really big one. And sometimes it could also be gastric cancer, because gastric cancer also can cause this ulcerations as well, these malignant ulcerations. So I'd watch out for peptic ulcer disease, by far the most common. Does patient have a history of dyspepsia or history of peptic ulcer disease? Have they had any anorexia, nausea, vomiting, weight loss, anemia that would suggest cancer? Think about that. The next one would be bowel ischemia. Bowel ischemia is a really terrifying one. And this is where the bowel is having long periods of no oxygen being delivered to the tissue, so it starts to become profoundly ischemic. And if not reversed in an appropriate amount of time, the bowel will begin to die. And so what you'll see is you'll see areas of ischemia here, but potentially maybe it's actually started to infarct. And as the tissue begins to infarct, it's super weak, right? It's super weak. And then if there's any rise in the intra-abdominal pressure for whatever reason, this 100%, not a problem whatsoever, can easily perforate through that weak point in the bowel. And so this is definitely 100% a big trigger for patients perforating. I think the big things to remember of what causes this is it's usually vascular or it's bowel strangulation. So the bowel is kind of being obstructed and it's really distending, and then it's stretching and compressing the arteries within the bowel wall, or you're strangulating the arteries within the bowel wall, or you're obstructing the arteries within the bowel wall. And so usually the things that cause this, I would really look for this in like bowel obstruction. All right, this would be a huge one. Usually the most common causes are going to be adhesions and hernias. Hernias are a really, really big one. And volvuli, they can really create closed loop obstructions. And the other one is called mesenteric ischemia, because this causes profound ischemia to the bowels. And this can 100%, if not treated and reversed, can definitely cause bowel perforation. So I would definitely think about this one in a patient who has underlying atrial fibrillation or recent cardiac surgery, aortic aneurysms of some sort, through a clot, and they have intense pain out of proportion. Or a patient who has cramping abdominal pain, abdominal distension, vomiting, obstipation, constipation with recent abdominal surgeries, or a visible hernia, something to that effect that would really make me think about a bowel obstruction that's gone wrong. The last one is infectious lesions, and these are really bad ones as well. And there's three particular ones that I want you to remember. One is if you hear a patient presenting with that classic migrating abdominal pain, periumbilical that moves to the right lower quadrant, and then they have fevers, leukocytosis, and they have this terrible findings of appendicitis signs, right? So the psoas, obturator, Rosvings, all of those things, McBurney point tenderness. I would definitely think about appendicitis. And whenever these things are super inflamed, they distend, and they cause arterial compression, ischemia to this bowel, and they can perforate. Same thing, patients who have what's called left lower quadrant pain with a history of diverticulosis, now they present with left lower quadrant pain, fever, leukocytosis, and now this diverticula has become so inflamed, so distended, it's compressing off the arterial circulation, leads to ischemia and perforation. Or lastly, a patient has what's called toxic megacolon. This is a really terrifying one as well, but they have massively dilated large bowels, usually at the distal colon. They have intense left lower quadrant pain usually. They may also have associated diarrhea and potentially like a bloody diarrhea. And that's a really scary one, along with fevers and also leukocytosis. So if you see systemic features along with localized areas of pain, this one is just usually more radiographically defined as when this large colon is greater than 6 centimeters. So these are the big ones to think about, because as they become super inflamed, they also can cause distension of the diverticula, distension of the appendix, or distension of the large colon to the point where they can cause perforation. And these are already infected and inflamed materials. You're going to spew infected and inflamed materials out into the peritoneum, and you can really get septic pretty quick. The one thing I would want you guys to remember associated with toxic megacolon is there's 2 diseases that it's been commonly associated with. One is C. diff, and the other one is ulcerative colitis. And we'll talk about this when we talk about C. diff and about IBD. But these are big things to remember if a patient has recent antibiotic use. Now they have terrible abdominal pain, fevers, leukocytosis, bloody diarrhea, or if they have a history of ulcerative colitis where they've had common complaints of left lower quadrant pain, hematochezia, tenesmus, things of that effect, and now they're presenting again with worsening abdominal pain, fevers, leukocytosis. Now you're scared about a complication. So now that we talked about all of the pathophysiology, the causes, the presentation classically in a patient with bowel perforation or esophageal perforation, let's talk about the complications that can arise in these diseases. All right, my friends, so now we move on to the next part here, which is a patient who has an esophageal perforation. They come in with terrible chest pain, and we kind of think about their etiologies in good detail as we talked about before. I think one of the big things that you want to watch out for is these patients can quickly decompensate. So when they come in, they have chest pain, you suggest an esophageal perforation. There's some things that I think can help in aiding in your diagnosis, but there's also things that I want you to watch out for because they can definitely lead to mortality in these patients. So when a patient develops an esophageal rupture, right, we talked about this a little bit already, but whenever they perforate or they rupture, they'll leak particular contents into the mediastinum, which is, again, we kind of talked about this. This is your anterior component of the cross section, right, of the chest. And then this would be the posterior portion. This would be the lungs. This pink stuff here is your mediastinum, heart, trachea, esophagus. When the esophagus perfs, you can release a couple different contents in there, such as air, which is definitely common. We swallow air pretty consistently. And in green here, bacteria. The developmental complications that we see here are the result of the air, the bacteria, and other contents leaking into the mediastinum. So let's say that we use the first one, air. So if air leaks, right, so you develop what's called an air leak, right? So we'll say that this patient develops an air leak into the mediastinum. When this happens, we lead to this disease, which is called pneumomediastinum. So it's called a pneumomediastinum. And it's literally what it sounds like. There's air that's actually occurring and taking place inside of the mediastinum. Now, does that cause any particular symptoms per se? Not necessarily. Whenever patients do have rupture or perforation of the esophagus, that air, it will kind of rupture into the mediastinum, but some of that also leaks out. And it leaks out into kind of these areas near the chest and near the neck. And so that can kind of get trapped in the subcutaneous tissue. And so sometimes we'll see these air pockets that can occur near kind of the infraclavicular area or in the neck. and it's usually trapped in the subcutaneous tissue. And so we call that subcutaneous emphysema. So one way that we may see this is we may see what's called subcutaneous emphysema. And that may be present on the chest x-ray, that may be present on palpation. One way that we can see this is you'll have what's called, as you're kind of palpating the chest and touching around the chest, you may feel like these Rice Krispies kind of like crunching under the chest. And that's called Hammond sign. And I would watch out for that, especially in your exams. If you see the term Hammond sign, it may suggest that this patient has subcutaneous emphysema from a perforated esophagus that's led to a pneumomediastinum. So that air leak could potentially cause all of these features that we just discussed. So look at the actual chest x-ray for air that's trapped in these particular areas in the subcutaneous tissue, and then palpate to feel for any crunchies that could suggest Hammond sign. All right, that's one potential complication. The other one is, let's take the bacteria now. There's a bacterial leak, and we'll call this bacterial translocation. Now what happens is this bacteria will translocate from the esophagus into the mediastinum. And when it does that, it causes inflammation. I'm representing that here in pink here, inflammation of the mediastinum. Now the mediastinum is kind of supplied by a lot of fibers that causes pain that can definitely be precipitated in the chest. And it's relatively diffuse. So this will definitely cause mediastinitis, inflammation of the mediastinum. And it's not far out to think how this will generally present. I kind of already told you that these patients will classically present with chest pain, all right? But here's the thing, the chest pain is often accompanied with systemic symptoms that suggest inflammation. And so what are those things that suggest inflammation? Fevers and white cells, right? So if there is an increase in the white blood cell count and an increase or precipitation of a fever, this definitely suggests more of a systemic effect, more of an inflammatory effect. So this is definitely inflammation related. All right, so it's not just pain, but it's also systemic inflammation that's definitely becoming present from this infection. The scary, scary concern is there's blood vessels all around this mediastinum. What if some of the bacteria translocate from the mediastinum into some actual blood vessels that are nearby? And so now these bacteria have spread from the mediastinum and they've gotten into your bloodstream. This can easily go around and cause systemic features of infection. And so now this patient has developed sepsis. And so it's pretty scary to understand here that definitely bacterial translocation or spread to the bloodstream could definitely be a very ominous sign, because now these patients will have bacteria within the actual bloodstream. And on top of that, this can definitely progress to not just having features of elevated white blood cell count, fever, tachycardia, but the scariest complication of sepsis is leading to septic shock, right? Which is where you have a constellation of findings such as an increased white blood cell count, fever, but usually hypotension, really low blood pressure to the point where you're not perfusing organs. And this is usually when we have seen a patient cross over from the mediastinitis findings over into the patient who is now septic with full-blown shock. Okay, so watch out for that. Let's now move into the next concept. A patient perforated their bowel. What are some complications and downstream effects from this one? All right. Again, pretty straightforward. It's not too complicated to imagine here that if you perforate the bowel, what do you release into the actual peritoneal contents? Same thing, you release air into the peritoneum, and you can release a plethora of feculent bacteria into the actual peritoneum. So now I've spread these puppies out here. Now, just the same concept, we're kind of repeating it here, if you will, but I develop an air leak, right, into the peritoneum. Is it a specific term? It's no different. If it was in the mediastinum, it was a pneumomediastinum. If it's into the pleural cavity, it's a pneumothorax. If it's into the peritoneum, it's a pneumoperitoneum. So same concept here. The patient has developed an unfortunate pneumoperitoneum. Now, in these patients, when they develop a pneumoperitoneum, they definitely can have increasing abdominal pain. But oftentimes when you kind of leak, just imagine it, just think about it. I have all this air that's kind of just accumulating into the peritoneum. It's like gas, if you think about it. What's it gonna do to the actual peritoneum? It's gonna kind of make it a little bit more high pressure. And so unfortunately, one of the findings is that they start to have a lot more distension. So they have more of this distending kind of feature. So look for increasing abdominal distension in a patient who's exhibited a perforation. All right, so if I see increasing distension, definitely kind of makes me think about a pneumoperitoneum. Also, when I go and I percuss, you're not going to have a lot of the normal sounds. It's going to sound like there's a lot of air. It's going to be super tympanic. The other concept that I want you guys to understand here is that pneumoperitoneum, oftentimes when the air leaks, the air loves to leak right underneath the diaphragm. And that's actually a really helpful diagnostic sign, because when you get a KUB or a kidney, urine, or bladder kind of x-ray, it really gives you a good idea, and you can see there's air leaking right underneath the diaphragm. It kind of signals a pneumoperitoneum. So that's really helpful to think about. Not just distension, it may be a finding that you see on an abdominal x-ray. The other thing is if bacteria leaks out. If bacteria does leak out into the peritoneum, so you get a bacterial translocation or bacterial leak, whatever you want to call it, the concept is the same though here, is that when these bad boys leak out, what will happen is they'll infect the peritoneum. They'll cause inflammation of the peritoneum. This thing will get super angry and inflamed, and these patients are going to be in a ton of pain, man. They're going to be in a ton of pain. And the unfortunate concept of this is that whenever they empty a lot of this bacteria and other fecal material in here, they're going to have so much pain. And usually the common findings for this is we call this peritonitis. And it's similar in the sense to mediastinitis, in the sense that these patients will have, and I'm not kidding, they'll have terrible, terrible abdominal pain. Very terrible abdominal pain. In the sense that mediastinitis had really bad chest pain. They're also going to have features of systemic inflammation though. So they'll have fever and they'll have an increased white count, suggesting a leukocytosis, right? And so I think that these are definitely not something that you'd want to think about for peritonitis. The other problem is not only is there intense abdominal pain with features of systemic inflammation, these patients have very specific exam findings. So when you go and you actually do a very good abdominal exam on these patients, they'll have peritoneal findings, we refer to it as. So peritoneal findings on exam. And ways that we look at this is in a couple different ways, and it's really important that you do know these. One is these patients will have a very rigid abdomen. So their abdomen will be very, very rigid in the sense that it's because it's so taut because of the pain and the inflammation of the actual muscles here that it's actually going to be causing a lot of, of the peritoneum, that's going to be causing a lot of pain. And this will be causing the abdomen to be super rigid. On top of that, their pain is so intense that they don't want anybody to touch their abdomen. And so they exhibit guarding. In other words, they really protect their belly and they don't want you to come anywhere near them to touch them. Sometimes you can test kind of guarding by kicking the bed. I know it sounds brutal, but it can cause an intense amount of pain. You don't even have to touch them. The other thing besides being super rigid and guarding is that these patients also have what's called rebound tenderness. So another one is called rebound tenderness. And what this suggests is that if you go ahead, you press on their belly, it will hurt, but it's gonna hurt so much more when you take your hand out of the actual belly. And that's a sign of rebound tenderness, which is a sign of peritonitis. So in a patient with worsening abdominal pain, systemic inflammation, rigidity, guarding, rebound tenderness, and if you want to add in there sometimes decreased bowel sounds, that also could really suggest peritonitis in a patient that is really could get sick. And the same way, if the bacteria does leak, I'm not going to go through this whole mechanism here, but if the bacteria does spread into the bloodstream, because there's tons of capillaries in the peritoneal area, if the bacteria do spread into the bloodstream, you already get the same concept here. It could easily cause a patient to develop what? They could easily progress to sepsis. So when the bacteria does spread into the bloodstream, they can get sepsis and they can look much, much worse. All right, so I think that's the big thing to be able to at least grasp from these patients is in a patient who comes in with bowel perforation, what are the types of causes? What are the potential complications and findings for an esophageal perforation? What are the causes and what are the potential complications and exam findings? Now that we've done that, let's go into the diagnostics. Patient comes in, right? They got bad chest pain. Maybe they have subcutaneous emphysema. Maybe they have a Hammond sign. Maybe they have some other features like a fever and a leukocytosis. Either way, I'm potentially concerned that they have an esophageal perforation. How do we go about diagnosing these patients? Well, first thing is if they have chest pain, if they have this subcutaneous emphysema with the crepitations when you press on it, and they have a history of vomiting, right, such as the Boerhaave syndrome, or recent EGD where they had some trauma to that area, you need to suspect esophageal perforation. So what do we do here? First thing is you get a chest x-ray. The reason why is if I get a chest x-ray, I'll be able to see, oh, look, oh, there's the pneumomediastinum. There's air in the mediastinal cavity. Oh, look, there's the subcutaneous emphysema where I was pressing and I was getting that precordial crepitations. That's the Hammond sign. Oh man, they definitely seem to have some type of esophageal perforation. So what I got to do is I got to kind of go a little bit further, right? And say, all right, if I see this, I definitely suspect that they have an esophageal perforation. What I can do here is if I really want to be able to see and definitely diagnose it, identify the location, maybe even learn a little bit about the etiology here, is I can get some further imaging. The thing that we would do here is we have to ask the question, are they hemodynamically stable? So in other words, do they have sepsis or septic shock? All right. If they don't, okay, cool. I'm going to get a contrast esophagram. They're stable enough that I can have them swallow a contrast and see if it runs down the esophagus and leaks into the mediastinum. Boom, I see the leakage right there. I've diagnosed it. The patient definitely has extravasation of contrast. They got an esophageal perf. And a patient who's not hemodynamically stable, they probably have sepsis. There's not a chance I'm going to send them to do that test. I'm going to get a CT scan. And I'll do a CT of the chest, and I'll be able to see an area of where the contrast is leaking out of the esophagus into the surrounding mediastinum. And that would be diagnostic for me as well. If I see the pneumomediastinum, if I see the actual extraluminal air, and I see contrast extravasation, I got an esophageal perf. From here, I've made my diagnosis. What about a bowel perforation? Again, same thing. Are they coming in with abdominal pain? Are they coming in with peritoneal signs? Are they coming in maybe with some history that's suggestive of a bowel perforation? Well, in those particular situations, I gotta suspect a perf. So what do? I want to look for a pneumoperitoneum. So I'm going to get an abdominal x-ray. Do I see air leak underneath the diaphragm? Yes, I do. They got a pneumoperitoneum. And from here, I have to ask myself the question right away. Is this patient hemodynamically unstable? Here's the reason why. If I have a pneumoperitoneum and hemodynamic instability, this patient is really sick. They have a bowel perf that's probably caused them to develop peritonitis, probably kind of pushing them into an area of what we would say is maybe even sepsis. I can't delay. I can't go get further testing. They need to go to the OR right away, and I'll do an intraoperative diagnosis where I open up their belly, find the area, oh, here's where they perfed. This is the potential cause, and then I'm going to treat it. So it allows for diagnosis promptly and treatment. In a patient who's more hemodynamically robust, I have some time. I can actually go ahead and figure out where the perforation is, and then help me to surgically plan out what I'm going to do. So here I get a CT abdomen pelvis. I can say here, oh, look, they had a hernia. And the hernia became so ischemic because it was a complete loop obstruction that it caused ischemia to the bowel wall and then it perfed. And I can see air here in my actual peritoneal cavity and then identify the etiology. So here I can tell right away I have a bowel perforation due to a kind of incarcerated hernia. In this particular situation, if I see a pneumoperitoneum and I find the etiology, I've found that the patient has a bowel perforation. And then now I can say, okay, here's what I got to do. I got to send them to surgery. And so that's kind of the whole point here, is if they don't have a lot of time, they're literally at risk of dying, you need to go to the OR. If they have time, you can find the actual imaging and you don't have to, put them at risk of opening them up if it's not completely necessary at the moment. Get the CT scan, figure out what the cause is, find if they have one, and if they do, then you can do surgical planning. So now that leads us into the appointment of treatment, kind of a nice segue here, which is, how do we treat these? Well, first one is esophageal perforation. In all of these patients, it's all supportive care right away. So in other words, you have to try to treat the injury. They perf their esophagus, they're going to need a surgical procedure. But in the interim, as you get them ready to go to surgery, you need to at least give them supportive measures. The first one, you don't want them to eat because the food's going to go right out of their esophagus and into the mediastinum. They're MPO. Replete their fluids and their intake with IV fluids. So give them IV fluids while they're not eating. Sometimes you may consider also starting them on antibiotics. I would definitely do this for all patients. The reason why is they have an opportunity for bacteria to quickly translocate from the esophagus into the mediastinum, causing mediastinitis. So put them on broad spectrum antibiotics, usually vancomycin to cover MRSA, and usually piperacillin, tazobactam, or cefepime to cover any type of gram-negative rod or any anaerobes. All right. While you're getting them the supportive care, antibiotics to prevent mediastinitis, hopefully sepsis and septic shock, fluids while they're remaining MPO, and so you can actually repair their esophagus. Then you get in there and you say, okay, is this something where I see the tear, I see the rupture, I see the perf, I can debride out the dead tissue or eroded tissue or where the trauma is, and then once it's clean, I can go ahead and now I have nice areas where I can put my sutures in and close up and repair this area. Cool. If the damage is too far gone, it's so erosive, there's not even enough area that you can suture together or repair, you may have to cut the esophagus and do an esophagectomy and maybe an end-to-end anastomosis potentially, or use another type of tissue to create the conduit between the top end of the esophagus and the bottom end of the esophagus where you remove the middle portion that was diseased. The next thing is a bowel perforation. It's the same concept. I cannot do anything for these patients except surgically repair the hole in their bowel. So until then, I need to give them supportive care. Do not let anything go down that oral cavity because it can potentially allow for it to leak right out into the peritoneal cavity. They're MPO. Give them fluids until we can actually restore a normal bowel. Put them on antibiotics because that bacteria can easily translocate into the bloodstream, cause them to become septic. Especially if the patient is having this, you should do this because, again, they're at super high risk of sepsis. Some people will be a little bit more conservative to say they develop a fever or leukocytosis, then I'll put them on this, but generally it's best to kind of keep these patients on antibiotics to prevent these kinds of scary catastrophes from developing. In the interim, you're surgically planning for these patients. Usually, you're treating the perforation by taking them to the OR. So whether this is intraoperative diagnosis, they come in pneumoperitoneum, hemodynamically unstable, they got to go to the OR, I'll repair it there, diagnose it there. Cool. If you get the CT, you find the perforation, the cause of the perforation, and you say, either way, I got to go into the OR and do the surgical exploration, not surgical exploration, but I have to go in and actually repair the hole in the small intestine because of a acute mesenteric ischemia or because of a peptic ulcer disease. I can do a laparotomy and I can say, okay, I can actually identify where this is. I'm going to go and do a gram patch over the peptic ulcer lesion. I'm going to go in and cut out the disease segment of the acute mesenteric ischemia, whatever it may be. It opens up the opportunity to treat the perforation itself. My friends, that's gastrointestinal perforation. I hope it made sense. I hope that you guys really did enjoy it. And as always, until next time.